So some of those who might qualify for so there might be some more people who qualify for Medicaid that might have not qualified for, but for the most part, the Medicaid system, if it stays the same, will have just a few more people be able to enter it. Now, if you are working, if you have an income that you don't qualify for Medicaid, you'd be eligible for the health insurance exchange, which is the exchange that we were talking about, which will be able to give you these minimum benefits. So it would be able to. So what these plans cover, and again, are based on what the market will be able to respond to. So if you have a generic HIV drug, it might be less costly than a brand new drug like the quad pill. So the newer technologies will remain expensive, and that's by no fault of the insurance company. It's really has more to do with how these things come to market and how these things are priced from the standpoint of the pharmaceutical companies. However, those costs are then passed on to the consumers, even when they're in a pooled plan. After if these coverages can't be covered, then Ryan White ideally is still the payer of last resort to be able to help cover these services. Next, please. So some terms that are important to understand is that when the new insurance exchange comes online, if you don't have a Social Security card, you're not going to be eligible for the insurance exchange plan, and you're not going to be eligible for Medicaid. So then the question is, who will cover those who can't pay out of pocket and don't have Social Security cards? So there's a couple of terms that are important to know. There's the qualified health plans, which are the insurance plans that were approved through the marketplace, as we had talked before. Essential community providers. Now, these providers are, in terms of the community, will cover medically unserved individuals or areas of low income. And so these could be defined by Section 340B, which is those that are for the federally qualified health centers, sometimes rural health centers. They go by different models, and also those who provide HRSA providers, including Ryan White and critical access hospitals. So these terminologies are going to be key to understand how to be able to provide access to those who you're serving in the community right now. Next, please.
Great, and I just wanted to make a quick comment. So with this exchange marketplace plans, those plans must contract with essential community partners. But there's a weak kind of state-federal effort with regard to how many and what types of essential community partners will meet the network adequacy standards in the marketplace. So this is just something to look out for, is looking to see how many types will meet the network adequacy standards in the marketplace, and what types. So this is just also something to kind of keep in mind.
So the federally qualified health centers, and they're in communities all over the United States. They've been around since the 1960s, and they come in different models. And we'll go through some of these models. But they're reimbursement designations by the Bureau of Primary Health Care and the Centers for Medicaid and Medicare. And they're designed specifically to be able to provide access to either a certain an underserved population or an underserved community. And the Affordable Care Act expands on this and provides more more coverage and encourages this model to be replicated more, especially in light that to be able to help as that safety net for those who won't have coverage within their within the federal within Medicaid expansion or the insurance marketplace. Next, please. So these are some of the models that exist. There's the community health center model, which is designed for underserved areas or populations. And for a community health center model, you need folks from the community to be on the board of the clinics. There's the migrant center. The migrant health models, they're also known as rural health. They specialize in culturally competent and primary prevention services for migrant and seasonal workers. There are the healthcare models for the homeless programs and public housing primary care models. All of these, have a lot in common. But there's also another category which is called a lookalike, and a lookalike leaves a little bit of room for creativity. The lookalike model, one would propose to say that they are either that they have an underserved population or they're in an underserved area, and then design it for the uniqueness of that population or that area. So in some cases, we might see the federally qualified health centers use an LGBT model to develop an LGBT clinic under the guise that to be able to address LGBT health disparities and access to care within that particular community, because they don't fit into it, because this particular population may not fit very well into the models that currently exist in their community. So that lookalike model is something that folks can look at within, clinics can look at to see if they're going to look for federally health qualified status as to what is the population that they're serving and how that works for them and their community. Next, please. So this is the Ryan White Act. Actually, when I was researching this recently, I didn't realize how long the name actually was. It's an act to amend the Public Health Service Act to provide grants to improve the quality and availability of care for individuals and families with HIV disease and for other purposes, also known as the Ryan White Care Act. And so this was an act that was enacted in 1990. Ryan White was a little boy who had hemophilia, who was a hemophiliac and had acquired HIV. He wasn't allowed to go to school in Indiana where he was living, and he became an advocate for HIV, and his story became very well known, and even after his death, his mother continues to advocate for services for HIV, and at every reauthorization she's been at the signing. Next, please. So these four guys should be familiar. They have all signed the Ryan White Care Act. It started with George H.W. Bush, who was the first one to sign it into law. And the law called for reauthorization, and every few years calls to be reauthorized. So it was reauthorized in 1996 and 2000 under Clinton. It was reauthorized in 2006 under George W. Bush, and then in 2009 by President Obama. And the 2009 Congress authorized it until 2013, where we are now. So the Ryan White Care Act effectively should be under reauthorization this year. So to understand where we are, we're at a bit of a crossroads here because we just had the Affordable Care Act that was signed into law since 2009. So there's a lot of questions that are lingering as to where does Ryan White go from here. And the Ryan White CARE Act is something that it's being studied very carefully to find out what services fall under the Affordable Care Act and what services don't. So I want to kind of help us understand at what point, for what points we still need the Ryan White CARE Act, and at what points will the Affordable Care Act come into play. But more importantly, what does the Ryan White CARE Act do, and what can we do within our communities to advocate for our populations? Next, please. So the Ryan White CARE Act was, funded originally in 1990. Well, it came into law in 1990. It was funded for the 91 fiscal year, and as you can see, the yellow dotted line, this has been the funding trajectory. However, the cases of HIV continue to rise, but the amount of money haven't. We know that inflation, the cost of living has gone up. The cost of healthcare has gone up. We have more people. With HIV, and we have more people. The prevalence of HIV continues to rise, even though not everybody is diagnosed. So there is part of the issue with the Ryan White CARE Act is that it started out funded according to the cases that we have. But over time, HIV has become a chronic disease. We used to consider it a fatal disease, and so now we have people who are living with the disease longer. They are needing they're in chronic HIV care, and also receiving medications for longer. Effectively, we should also be seeing that they're having a better quality of life. But that also means that the money has to. The question is whether the money is available to be able to help sustain the care and the medicine that they need. Next, please. So I'm not sure who's familiar with this. You can raise your hand if you're familiar with this chart right here, and maybe somebody can tell me what it's called. Is nobody familiar with this?
Stephen raised his hand, and so did Lena.
Lena raised her hand, and Stephen, what is this called?
The Gardner Treatment Cascade.
Thank you very much. Next, please. The Gardner HIV Treatment Cascade. Excellent. And this is so to understand what the Gardner HIV Treatment Cascade is it's the best way to be able to perceive this is that this is a tool. This is a tool which helps us understand where we need to focus. And the way that this is designed is that these are the areas that we work in to be able to help continue care. And so the Gardner Cascade provides us the information that we need to understand where services need to improve, but also where resources need to go. So keeping an eye on this cascade and there's different forms of it. There are state-by-state models. There are models that go by race and ethnicity. There are several different models of this cascade. This particular one, it looks at the U.S. as a whole. But really the point here is that we see that of all of those who are HIV infected, not everybody is diagnosed. So there's a lot of people out there who don't know they have the virus. And in order to be able to reach what we're calling an AIDS-free generation, we need to be able to level out this cascade so that it isn't a cascade or it doesn't look like a set of steps, but it is a bar of lines that are all parallel. So if we look at what the National HIV Strategy is focused on, helping people who are undiagnosed become diagnosed so that we can link them to care, so that we can keep them in care, and we can get them the treatment that they need so that they have an undetectable viral load. Well, as we see here, there's about an average of about 25% of the people who have HIV have an undetectable viral load. And so this is where some of these services will still need to be a part of. So when we look at the GARD Cascade, I think it's important to look at it for what it is, and that's a tool to be able to help us know where we need to focus. Next, please. So let's see where Ryan White is still important to us after the Affordable Care Act. The key issues that are important when we're looking at this is how do we support people with HIV at each stage of the cascade? And this is the Kaiser Family Foundation to say is really a fantastic resource for all of this information. This really comes from a lot of their own reporting, and I encourage you to look at the Kaiser Family Foundation website for more information on Ryan White as well as the Affordable Care Act. But going back to this, supporting people with HIV at each stage of the cascade is really important. Building HIV networks in underserved communities, communities where we see higher incidence rates. We're seeing higher incidence rates in the South. We're seeing higher incidence rates in smaller towns than we had before. Making sure that these, not just building these HIV care networks, but also strengthening the networks that exist. These are opportunities for those of us who are working in the community to be able to provide a voice within these networks to make sure that our communities and our populations that their needs are being met. Also integrating HIV care and expertise into the main healthcare system. As I mentioned before, a big aspect or a major aspect of the Affordable Care Act is how can we lower the price of healthcare? How can we lower the cost of healthcare? Well, there was a time when it was absolutely necessary for folks with HIV to go to an HIV specialist. Now the tide is turning more towards how can we educate and build the capacity for primary care physicians and nurses and PAs to be able to treat those who have HIV. There would still be cases where those with HIV would still need to go to an infectious disease specialist, but we're now looking at with the technology the way that it is, with the medicines the way that they are, how can we provide care closer to where people live within their own communities, within the same clinics that people go to for whatever primary care they go to. And then effectively and fairly allocating Ryan White resources. And so this is another area where we fit in here. Who oversees, understanding who oversees the allocation of Ryan White? What do the different parts mean? And where do they go in your community? And this is going to be the subject of what we talk about next.
Hey, Eric, we have a question from Stephen about the treatment cascade. He wants to know it says, with the treatment cascade, the percentages change depending on what number is used as a denominator.
And by that I mean, if we look at the number of people that are HIV infected and determine our percentages with the downward scales according to the HIV infected as opposed to those that are diagnosed, those percentages are going to change. So I was wondering if that's why you have those gray areas in the 3 lower bars.
Yeah, absolutely. Because this is really modeling, and so the gray areas are what as much as we know. So 25 becomes the average within that area. It could be as low as 16 or as high as 36 for an undetectable viral load.
But is that dependent on whether or not you use the total number of people infected, or just those that are HIV diagnosed, or just an average?
Yeah, exactly. So this is based on the denominator would be those who we would think are all HIV infected. So so of all of those who are HIV infected, the lowest bar is based on that.
Got it. Okay, cool. Thank you.
Sure. Okay, so going back to the Cascade and where Ryan White services meet the services. So Ryan White, the program allows for HIV testing and counseling, which meet for the first Cascade, outreach and engaging in care, health insurance premiums, and cost sharing, non-medical case management. This is the case management that the difference. There's case management that occurs on the medical side, where the case manager serves as a liaison with the medical providers, and then there's the case management that would occur in the community, where they are provided services to help support them in the community. Also, medical transportation, medical case management, as I said, which will also include helping people, do things like pack a pill case, help them with adherence, help them, refer them to other ancillary medical care that they might need, or mental health. Referrals for health and support programs, treatment adherence. Also, one of the things that isn't listed here, which Ryan White can provide, is linguistic support, like interpreters, and the cost of translating documents, and that is, which is for many of our populations, are really important as well. But as also we have to look at some of the challenges that we see, especially with Latinos in the South. A lot of it has to do with transportation. A lot of it has to do with linguistics and support, particularly out in the community. And then if they are people who don't have Social Security cards, it's still going to be essential to be able to help provide them with care, to be able to pay the care in some way. And so this is where the Ryan White services come into play. Next, please. So we don't have a crystal ball as to what Congress is going to do, moving forward. It's hard enough to tell how much they agree or don't agree on anything. But what we do see are are certain signs of what might be coming up in the future. So, a couple weeks ago, 2 weeks ago, was the third anniversary of the signing of the National HIV Strategy. And so President Obama took the opportunity to sign an executive order. The executive order sees through HIV care continuum. It's a HIV care continuum initiative, and the programs that are through this are effectively funded through the Office of the Executive, and also carry forth a lot of the programs that we already see as part of the Ryan White Initiative, which include, a lot of the idea of support services, building the capacity for providers to be able to provide HIV care on at primary care clinics, and to be able to initiatives that are aimed at addressing stigma in the communities. So as much as we don't know whether the operation will actually occur, we can see that the Office of the Executive is taking some initiative to make sure that these gaps are being covered, and will only we'll have to pay attention to what's coming forward, and what other executive orders might move forward. But also pay attention to what Congress is doing when it comes to the reauthorization, because I myself don't know at what point they plan on addressing it, or better yet, what is the right time to start addressing it when we look at everything else that's going on. But it's important to see the types of executive orders that are coming out at this point to be able to help cover some of these gaps. Next, please. So let's look at what Ryan White does in all of the parts that Ryan White covers. You know, they're I don't think particularly creative by calling it Part A, B, C, or D, but this is what they're called. And if you have one of these grants, you probably are aware of what these things do. I've emboldened the ones that that are specific to access to care. The special projects for national significance are kind of the research and development arm of HIV. They provide research projects and initiatives that are kind of tried through demonstration projects to see how the effectiveness of them rolling out in a clinical or community setting. And there's the AIDS Education and Treatment Centers, also known as the AETCs, which are used to build the capacity of medical providers and keep them up to date on the latest technologies, and be able to help train providers to be able to work to provide HIV medical services. And so these are some of the programs that are also being expanded as part of that Continuum of Care Act, because it's becoming more important for the AIDS Education and Treatment Centers to be able to help provide the services to medical providers that might not have been specializing in HIV before, and might have just referred in the past to get them ready to be able to provide these services on a local level. And then the minority AIDS initiatives are money that are built into, there's kind of special projects also to be able to help address issues of, say, stigma or underserved minority communities that are affected by HIV. Next, please. So let's go through some of these parts that have to do with access to care, because what's important here is, I think, understanding what this money is intended for, who it goes to, and how we as leaders can keep an eye on where this is, and advocate for our community wherever we need to. So Part A funding is intended for continuum of care, medical and support services. And so it's really provided for core medical services, but it's not provided everywhere. It's provided based on your area. Either you're in an area that has a high HIV incidence, or a population that has a high prevalence or incidence. Now, the way that these money is allocated is that it's allocated by what they call a 75-25% rule. 75% of the money goes towards medical services. 25% of Part A money goes towards support services. The money is typically allocated to a chief elected official, typically the CEO of the organization that sees the most HIV patients and services within that community. But that person doesn't get to make all the rules. That's just the person who, for the most part, signs the checks. There's a planning council that would help make these decisions. So next, please. So the planning councils set priorities for the Part A based on the size and demographics of the people living with HIV in their area. To be able to help advocate at these planning councils, well, first you need to know where these planning council meetings are held, how can you get onto these planning councils. But then once you're there, it's also important to understand your local epidemiology and the demographics of your area and who's being affected. The money is intended to be proportioned according to the need of the community itself. So to be able to help advocate for your community, you have to be able to make the case that those who you're serving have a need. And so, you know, a combination of the type of stories that you see, the narratives of the people that come to you, along with data, you know, empirical data, especially, you know, that everybody can clearly see that there's a need, is a really important way to be able to advocate. So, so if you can, you know, get on these planning councils and be prepared to advocate for those that you're serving. Also, help them understand what are the types of wraparound services that your community needs. If you're in a community that needs more linguistic support, but the money isn't really allocated towards linguistic support, say interpreters or to help interpret documents or to translate documents, you know, these are areas where you might be able to make a case, as well as transportation, mental health services. You know, helping them understand who your patients are, and the need is going to be the way to be able to help advocate. Now, it's also important to know that there are a lot of competing interests, and that's the reason why it comes to a planning council, because these interests have to be weighed by the interest of the community. But you know, this is what health equity is about, to be able to help provide the services for all that need it, because this is what we're looking to do, to create the optimal level of health for everybody. So also participate in the subcommittees and work groups. That's really where your ideas have an opportunity to shine. They take up more time. They also take away they might even take away from some of the work that you're doing, but in the realm of work that you're doing at back office, but in the realm of advocacy, the subcommittees are the ones who are able to sort of propose plans. That's where creativity happens, and it allows you to provide even more of a voice, because it puts you in a smaller group, and to be able to help make that case.
Eric, can you tell us where they can learn about where there are HIV care planning councils in their area?
So if we go to the next slide.
Oh, wonderful.
So there's two types of the council. This is by eligible metropolitan area, and so the eligible metropolitan areas, there would be Part A planning councils in these areas, and so the ones that HRSA right now has designated is, you know, based on incidence, but we'd find them at least within our southern region in Georgia, Dallas, Houston, and New Orleans. So these would be the areas in which you would be able to these would be where you would find them. Your local health department would probably be the place where this is that would coordinate. If not, you would also be able to find out by knowing who the largest HIV provider in your region is, and asking them if they're a part of this and how you might be able to be a part of it yourself. Next, please. The other way to get Part A is if you're in a transitional grant area. And so these are also areas that have a great need, and I've also highlighted the areas which are in our southern region that are transitional grant areas. Now, one of the things that we're seeing in a lot of the states is that these planning councils are combining with the prevention planning groups. At least that's the case that's happened in North Carolina, because as we see moving forward, prevention care is what we now see care as prevention. You know, there used to be a medical model and a public health model, and now the medical model and the public health models are combining, and so a lot of these services, so a lot of these planning councils are now joining forces, so that because looking at care as prevention. Next, please.
We have a comment from some of our Texans. They want to know why San Antonio and Fort Worth are not highlighted, and that's happening in Houston too.
Were they on the list? Oh, yes, that's right. Okay, so why? The reason why is because that's my mistake. That's the reason why.
Sorry. And
that was
Stephen
my
is
bad, excuse me.
That they have developed their current comprehensive plan in conjunction with their preventative partners at their local health department. Oh,
that's great. That's great. And so, you know, the important thing here is how can we be a part of those? Because you don't always have to, these are typically open meetings, you know, just knowing where they're at. You don't always have to be a voting member, but you can, just your presence there makes a difference and shows that you're advocating for your community. Just knowing that you're, just knowing that there are there who are advocating for your community goes to show that this is something that that needs to be paid attention to. Because again, there are a lot of competing interests, but what you don't want is to be forgotten about, and you don't want your community to be forgotten about. Next, please. So Part B is granted to the states and territories, and this is where our ADAP money comes from, the AIDS Drug Assistance Program. When you can't pay, when you don't have insurance to pay for your medication, for HIV medication, the AIDS Drug Assistance Program would be the payer that covers it. The Part B programs, you know, they're granted to the state, and then from there, the state typically allocates the services either to their own medical facilities or other medical facilities to be able to cover in any specific area. This is also typically why when the AIDS Drug Assistance Program, you have to register with the state, and the state would pay a portion of it and then get reimbursed by the federal government. This also includes, and I've emboldened, funding for emerging communities. This has to be something that is written into their grant, and it is also it might be used in a specific way in which they proposed that it was going to be used. But if your state is applying for Part B money, the funding for emerging communities is also a way for you to advocate, to ask them to put this into the proposal, to ask the federal government for monies to be able to help the emerging communities. And this is where joining your planning councils and your work groups might be, is advantageous. Having a relationship with your state epidemiologists. They don't have to give you data, but it's useful to have it because they have as much as they need to do. So so developing a relationship with those who have the data that comes into the states from all of the clinics, that's also very useful. So so understanding, does your state have money for emerging communities? Is it eligible for funding for emerging communities? Does that fit into the scope of your work? All of these are important questions for you to look at in your own localities. And then eligible grantees may also pay for supplemental B funding. So, there's supplemental funds. It could be used for supplemental funds as well. Next, please. So Part B funding. So how is Part B money allocated from state to state? Well, so for you, it's important to understand which healthcare facilities receive Ryan White Part B money. How is that money being used? Which support services are being used for Part B money, with Part B money in your community? And so these are the areas that are important to pay attention to, and really follow the trail of where is the money going, and how is it being used, and does this fit into your work as well? Next, please. Part C money is designated for early intervention services. And so as we were talking before about the federally qualified health centers, federally qualified health centers are eligible for C money. Family planning programs, comprehensive hemophilia diagnostic centers, rural health clinics, the community health centers. These are the entities that are eligible for Part C money, and Part C money is key, especially looking forward at the Affordable Care Act, because this is where we're seeing that the funding will be going to be able to help cover those who aren't eligible for insurance. And that aren't eligible for Medicaid as well. These are knowing where the federally qualified health centers are that receive Part C money may also be, you might work for one right now. If not, you might also be aware that that this is that if after January 1st, it becomes more difficult to be able to provide services that it would be important to be able to help transfer care to somebody who can cover the services adequately, and knowing who it is that can provide these services adequately. I haven't stopped to ask if you guys have any questions. Do you guys have any questions that you guys want to say out loud?
Not really a question. I did put a comment, and I saw that Dina put it up there about non-voting members being able to make public comment at meetings. All the Ryan White Planning Council meetings are subject to the Open Meetings Act, so you have to basically put out there when you're meeting, what time, and where, and if you can, part of the agenda, or at least the highlights that we're just speaking about. But anybody in the public could attend one of these meetings. They all have a public comment section where you can sign in, and if you have something you wanted to say in support of something that they're having to vote on, that's your opportunity to do that. That's
a really great point. Thank you for saying that. This is that's really important. I think that is where we as community leaders have a lot of power. We have a lot of power on our local levels, especially within our communities. A lot of the people who go to these meetings are our own colleagues, and I think that the best way to be able to make your case is by providing a combination of empirical data and important narratives. Next, please. So for Part C, are you familiar with the Part C providers in your community? Are you familiar with who the community health centers are, the rural health clinics that are providing HIV services? And do they have the capacity for monolingual Spanish-speaking and immigrant populations? So if they're a rural health clinic, then that would effectively be part of the model. But in some cases, you might have somebody who fits into a rural health clinic model, but there might not be that model available for them. And so helping understand where those ancillary services might come from also, even if they don't come from within the clinic, perhaps they might come from within the community and perhaps from another part of the Ryan White system. Understanding these nuances for your clients are a really important way to be able to help advocate to make sure that they are covered with the services that they need moving forward after January 1st. So Part D, and Part D provides services for women, infants, children, youth, and their families. So this is provide services for also, inclusive of those who are receiving perinatal care, children who are born to mothers with HIV. This will help pay for their testing them, pays for the medications. The incidence of children born to HIV-positive mothers has been significantly reduced, but that doesn't mean that that when they're first born, there's still added care that needs to come out of this, and that care costs money, and so this comes from the Ryan from Part D system. A key thing to this Part D, though, is that we're seeing the incidence of HIV continue to rise with younger people, and we're seeing the average age of incidence getting younger and younger and younger. And so the Part D program, we see it like you might see somebody who's 18 years old who's newly diagnosed, and we think of them as an adult, but the Part D program covers you up until your 25th birthday. And it provides some nuanced services that are key, especially in these adolescent and developing ages, that can be used for such simple things as learning how to set a timer so that you take your medicines on time, and added support to be able to help get you to your clinics appointments. Even though they come from different case managers or workers might come from different, might be funded through different parts. You can work together to be able to help make these things happen for youth clients or for other clients. Also family-centered primary care and specialty medicine and support services. Next slide. So, the questions here is: do Part D providers have the capacity to provide services for Latinas in your community? And so the question here is: do the Part D providers are they linguistically competent? Do they have the linguistics to be able to provide services for women in your community, and understand the cultural context within the community? Also, are they able to provide services to 18 to 24-year-old immigrant men? We know that of the emerging communities, part of what makes the Latinos emerging communities in the South are really the two major factors. At one point, we saw a lot of people coming from other countries and also from other states, but then also we see a lot of births. And so youth are still vulnerable, but then also we see that a lot of people who have come from other places come when they're very young. The median age in a lot of our states is typically under 24 years old, and so it's important to understand that they still fit into the context of Part D up until their 25th birthday, and that they can be afforded services under Part D up until then, and so it's something to keep an eye on when advocating for your community and for your clients. Any questions at this point about the Ryan White CARE Act and all of the parts? I didn't include dental. Basically, dental is a grant that would go to dental care providers, specifically dental care providers, to be able to help provide dental services in the community, and that's also a lot. Typically, the way that happens is that they're referred by their medical provider for dental services. But otherwise, these are the. I want to give you guys a clear overview of all of what we call the parts, which are essential to providing access to care and especially support services moving forward. So, is there any questions from all of you? Any of you who would like to speak out loud?
We have a question from Val from Texas. He wants to know, how is the money distributed among the EMAs?
The EMAs, those are the ones that typically you would probably look to who the largest HIV provider is in your district, and the administrator would probably is likely to be the CEO of that organization, but the money is allocated based on the planning councils. And so the planning councils, they deliberate over the need within the community, and then they would proportion certain amounts. So we have a certain amount, we create a budget that a certain amount would be used for transportation, a certain amount would be used towards adherence, a certain amounts might be used towards linguistics, a certain amount might be used for testing. So that they deliberate it. The administrator, for the most part, is the one that signs that has access to the accounts and signs the checks to make sure that everybody gets paid. Does that answer it? Does that cover it?
He wants to know between the different cities, how is that determined?
Oh, how is that determined? That's determined based on by incidence rates. That's determined based on how many people live in an area with HIV and what the incidence is. Meaning, so the prevalence is how many people have it within the population. The incidence is how many people are getting it within a population. So there's the HRSA and the HIV/AIDS Bureau have a formula to determine which are the areas which will become EMAs and TGAs.
And we have a comment from Stephen where he says, based on prevalence need and some EMAs are also held under a hold harmless provision, which puts a cap or a line under which funds may not go under if being reduced.
Right, and so I guess that would also be like from locality to locality. I mean, like for Part A, there's a 75-25% rule, so they can't use more than 25% for support services. So there are. So this actually makes really good points. Understanding. I'm here providing you a framework, but what happens within your own communities and how these things play out. This is really what I'm trying to get you guys to understand: the importance of participating as part of these planning groups and these planning councils in your area, and understanding not just the rules, but also understanding who comes to the table. And who's advocating for their community, and be recognized as one of these players that comes with good information and good data, and can still make a case and understand the competing interests of the community as a whole, not just try to leverage it for your own sake, because I think for the most part that may not gain you as many friends. It's important to understand the community as a whole, as well as your interests. Cool. So moving forward, let's talk about the states and where the money is going to the states. Starting with Alabama. Well, Alabama does not receive Part A money. There are no EMAs or TGAs within Alabama. But they do receive, but Alabama does receive Part B money that goes to the states and territories for medical assistance, for the AIDS drug assistance program, and for emerging communities. And so I'm just thinking. So I know Jean's there from Alabama. Are there other people there from Alabama?
I don't think so.
So Jean, do you are you familiar with how money is being used for emerging communities in your area?
I really don't. I began to go to the HIV Prevention Network. I know that they do the one in the States. I have not been there because it's at Montgomery, but this gives me the opportunity to ask for it. I will definitely ask for it.
We also see here that there's the Part B money also for the Minority AIDS Initiative. And so those are other areas in which Part B money comes. There's also a good there's a good amount of money for early intervention, the Part C programs, which would be your federally qualified health centers. There's also that to understand where they are and how they can provide access to services. So, for instance, for Eugene, understanding where the federally qualified health centers are in the Birmingham area and surrounding area can help you understand better of where some of the folks who might not have Social Security cards might fit in better when it comes to being able to help provide them care.
Yes, and also there's a huge problem now with the clinic, at least in Birmingham, that they have interpreters available, but not always. So there's maybe 3 or 4 staff that are bilingual, but that doesn't mean that they're always going to be with the client is there. So sometimes I see myself doing interpretation. So that's a huge need that we have to address.
Yeah, absolutely. And this is in the point that I'm trying to gather here is like we see the problems within our communities, but also just seeing where's the money coming from, and what's the money being used for, and can any of this money be like within the guidelines of how it's supposed to be used? Is your population eligible for it to be routed in this direction? Because sometimes it's just a matter of the fact that nobody's asked for it, or nobody's presented the case. Out of sight, out of mind. If you don't have people from the community coming to these meetings, it's really easy not to have to, and that it's really easy to say, well, I guess there's not much of a need here. There isn't anybody here from the community to represent.
And you're so right, because it makes sense. The documents, when you go to the first orientation, when you're a new client, everything is in English. They don't even have the documents in Spanish. So that's a really need that we have to address, and thank you so much for this information.
Oh yeah, absolutely. It's a pleasure, and yes, so it's good to know that there is money that is available to do that. Now, the challenge there is how can you get the money routed in that direction, and you'll learn that based on kind of following the trail of where it comes from and how it's allocated.
Thank you.
Next slide, please. So now to Louisiana. Louisiana has both an EMA and a TGA, and so they receive quite a bit. In fact, New Orleans has the second highest incidence in all of the country, if I'm correct about that. And so they do receive quite a bit of Part A money. Also, the states they also receive Part B money and ADAP money, though they don't receive money for emerging communities. The challenges from state to state are different, and so I don't know if is anybody from Louisiana on the line.
Christy's Louisiana, but she's out on maternity leave.
Well, this is so understanding this, and I think Louisiana, makes a good is an interesting case though in itself, because it's a southern state. It has an incidence rate that has been on the map for a very long time, and in a very well established system. And so understanding the money that they get, how this money is being used within there, is key to being able to help advocate for your community. Because in some cases you're advocating outside of your organization. In some cases you're advocating within your organization. So it's important to see where it is that you need to be asking questions of, and where it is that you need to be making and stating a good case. Next, please. South Carolina. So who do we have on the line from South Carolina today?
We have Miguel and Elsa. I think their phones are muted. Sorry.
Miguel and Elsa. So this is to be able to help you understand what's going on in your state. South Carolina doesn't have an EMA or a TGA, so they don't receive Part A money. They receive money from Part B from the states, and for the AIDS Drug Assistance Program. There's also money for the emerging communities. And so, I don't know. So, emerging communities would be a kind of a wide category. So, I don't know specifically how that money is being used. Usually, there's a proposal that comes in the first place, which is why they give them money for emerging communities. So, it's important to understand what that money is being used for, because underserved immigrant Latinos in the South could be considered emerging communities. Also, early intervention, understanding where the community health centers are, the rural health centers that can cover HIV services as part of the Part C program. And then the Minority AIDS Initiative. There's Minority AIDS Initiative funds that also go to South Carolina as part of this, and so understanding what the purpose of the Minority AIDS Initiatives are, and understanding whether your populations might fit into these initiatives. Could be a key way of understanding what kind of resources might be afforded to you in your community. Next, please. All right, Texas. I didn't forget about Texas. And Texas is a large geographical state. Also has a large population. Also has proportionally has a large prevalence and incidence of HIV. So they receive quite a bit of Part A money, as well as Part B money. In fact, what we don't see is emerging money for emerging communities. So as you can see that in Texas, there's a lot of local control, state control of money, and it seems that from the feedback that we've gotten here, especially from Stephen, that there's a good understanding of how these planning councils work in the local area. So I kind of just want to leave you guys with the importance of a basic awareness of what kind of monies are coming in through HRSA. This is not money that comes in. This isn't money that comes in from the Centers for Disease Control. The money from the Centers for Disease Control is money that is allocated towards prevention and preventing services. However, as I mentioned before, the public health models and the medical models are combining. The monies that have been used traditionally for the medical models that have come through HRSA and the HIV/AIDS Bureau are now need to have more of a reach into the community to provide these wraparound services into the community for prevention and care, for testing, for instance. The monies that are being used for prevention are also having more of a focus of what happens within the clinic. So we're seeing a lot of overlap. So this is only one of the systems. The systems that come from the Centers for Disease Control are allocated differently and can also be complementary to how this money is being used. So I give you an example that in North Carolina, we have our prevention planning group and our care group has joined forces. That's by design. The prevention group typically gets their direction from the CDC. The care group gets their direction from HRSA, and now in the state that they have to work together in order to be able to maximize their effectiveness. And that's I leave you with this. I want to ask if you have any questions, comments, concerns, complaints. I'll take complaints.
No questions?
I know I got one. I got one complaint. I got one complaint that I left some of the Texas cities, and I apologize for that again.
All right, so it looks like we don't have any questions, or that's the way it seems, but I compiled a list of resources on the Affordable Care Act. I mean, I think that when Eric and I started talking, we saw that there's so much going on with the Affordable Care Act, it was difficult to kind of choose what to include. So I included in our resources just information on premium tax credits and cost-sharing subsidies. There's some great notes in that section about ADAP and how it'll affect people with certain income levels and people, with Ryan White and the Affordable Care Act. So definitely check that out. And then there are just some other resources, the Treatment Access Expansion Project, and then the HIV Medicine Association. They have media lists by state. So as you're working on your projects, if you're not sure who to contact for your media products, you can check out, enter the information by state, and it brings up everyone who, like all the different newspapers and all the different states. So that was a really great resource. Does anybody have any questions about that? We have a question or a statement from Jean. It looks like for the states that have an ADAP list and new clients uninsured.
Yes, that are not eligible for the Affordable Care Act. What happened with them?
Yeah, so in this worksheet, there was some great information on that. Like, it breaks it down by the federal poverty level, and even though, so some of the things that we can start encouraging, because it looks like a lot of states, even though right now they're not expanding Medicaid, we have these high hopes that they will expand Medicaid eventually, because it's what's making the most sense for this system to work in their state. And so this has some really great resources about, it like breaks it down for ADAP and people who are uninsured and who don't qualify for the health market exchanges.
I also wanted to add a caveat to that, and that we don't know. We still have a lot of questions moving forward, but we can see that a lot of the guidance that we've been getting has been changing. In the waiting lists are typically for people who are new to the medications, who haven't received the medications, but they've never been on the medications. They're still treatment naive. However, the guidelines, the medical guidelines are now changing, and so at one point it was that you don't need to be on medications unless you have 350 T cells, then 500 T cells, and now the recommendations are get on medication at any point. As soon as you know you have it, you should get on medication. So as these guidelines start changing, it also puts some pressure on getting people treated. The emphasis right now is on getting people treated, making sure that people take their medications, because this is where prevention is heading. And so this is an important case for you to also be able to make if you see that that you're in a position where you need to be able to make that case, is that the guidelines are telling us everybody, if they have HIV, needs to be treated, and it's not just for their good, but it's for the good of the public health. Good of public health, I mean, not of the public health, but of public health.
Thank you.
Okay, so just remember our next webinar is on August 13th, and we're going to be talking about HIV criminalization and what it means for immigrant populations, especially going through like immigration proceedings. So how that can affect it. So that's a really, we're going to be shifting gears a little bit on more social and legal justice information for our last webinar of the series. And then we'll have one more webinar about our projects. So I'm sending out an email with this information on this webinar, but also on the deadline for you all to send me your slides, which is August 14th is what I think I've been telling everyone. So the day right after our next webinar, we'd want to get some slides. And we're also going to be catching up with some of you beforehand, just to make sure you don't have any other questions. And my tour throughout the South continues. I'm in Alabama next week, and then shortly after, I'll be in Texas. So I will email out some dates for those of you in those corresponding states if I haven't already. But I look forward to seeing all of you very soon, and thanks for joining us.
Thank you, everybody. Thank you for your attention.
Thank you.
Thanks.
Thank you. Please stand by.